I'm Ingeborg Stalmans. I'm the head of the glaucoma clinic at the University Hospitals in Leuven, Belgium. I've been using the technology since April 2014, so I think that was pretty early on. I've treated about between 300 and 350 patients by now, so I think I can say that I have quite a bit of experience with this technology, and I would be happy to share my experience with you today. Positioning this new technology has been a bit of an adventure in my hands, because first I thought this would be reserved for advanced, desperate cases, and that's where I used it first, because I thought it would be similar to diode cellular destruction. But I noticed that these patients actually had a fast recovery, and the inflammatory reaction was very mild. And that's why I figured that we might use this technology earlier in the treatment step ladder. Currently, I'm using this technology rather as a pre-surgery option in patients that are not sufficiently controlled on drops, but where maybe I don't feel like doing surgery yet, or I can propose it as an alternative to surgery. I tell my patients that we can do this treatment first, that I expect that we have 70% chance that we will see a significant pressure lowering, and if not, we still have all the other treatment options open. We can still do surgery, being it invasive or minimally invasive surgery. I feel that the main advantage of UCP is its non-invasivity. You don't have an incision, so no risk of infection, bleeding, serious hypotonies, and other complications that we see with surgery. It's also a fast procedure, takes about 5 minutes, and with a very short learning curve, very straightforward to use, so can easily be taught even to residents. Another advantage is that patients have a fast recovery. There is very little inflammation. It is not painful. And also, very importantly, it leaves all the other treatment options open. You can still do any surgery you wish after this UCP treatment. In my view, this technology is ideal for primary open-angle glaucoma. I know that from the early results, the effect in very advanced cases, advanced being patients' eyes that had been operated several times, or very severe secondary glaucomas like neovascular glaucoma, etc. In these eyes, the efficacy was less good, which is not unlogic. Also with other technologies, the results are less favorable in these very advanced cases. So the results are best in the primary glaucoma cases, and since it is well tolerated, I think it makes sense to use it primarily in these patients. Well, the patients are usually very happy with the treatment. I use retrobulbar anesthesia, so I usually tell my patients the only bad part of the procedure is the injection to put your eye to sleep, which takes 1 minute. And after that, you can take a nap because they don't feel the rest of the treatment. It takes about 5 minutes in total, and they're usually surprised that it's already over. I tell them that it can be a bit uncomfortable the first day when the eye wakes up, and usually the day after they're comfortable, they're fine. Visual recovery is usually fast, and in most patients we already see a pressure drop on day 1, But I tell my patients that we have to wait for week 3 checkup for the final result. I believe that UCP will be used more and more in the future, especially before surgery. Probably as an alternative to trabeculoplasty, because I feel that this technology has more to offer efficacy-wise, and my feeling is that the effect lasts longer. So in my view, this will be used more and more between drops and surgery.